How to choose in 5 definitive steps which protocol to use. Rapid maxillary expansion or slow maxillary expansion. This is one of the biggest mistakes I see among doctors. So this video is a 5-step guide to help you know for sure. How should you act at different times? And what is the protocol or rapid expansion or slow expansion? All right. I'm Professor Rayane Pinto, an orthodontics professor, orthodontist, and postgraduate coordinator in Brazil. Subscribe for weekly videos on interceptive and comprehensive orthodontics, rapid expansion and slow expansion protocols. And this is a topic I like because since my doctorate, I worked with these expansion topics. In fact, we recently wrote a chapter in a book about posterior crossbite. My team and I wrote a chapter showing and guiding on rapid expansion protocols, slow expansion protocols, what the key differences are, what possible treatments exist, patients we have already treated on this topic, and that's what I want to do in this video. I want to share with you the most important part of this chapter, which are the 5 diagnostic points about when to do rapid or slow expansion. But when should we actually perform an expansion treatment? Doctors think we expand when there's a posterior crossbite. And it's true that we expand when there is a posterior crossbite, which can be unilateral or bilateral. But there are cases where we will expand for other reasons, such as where there is a compression of the maxilla and the mandibular part, the lower alveolar arch compressed. You don't have a posterior crossbite, you have compressed arches, which can mislead doctors. The doctor looks, does the clinical exam, and sees no posterior crossbite. Well, in reality, that's a false impression. I need to expand the upper and lower arches. Another situation, not common, is when expansion is necessary. With mild or moderate crowding, I see maxillary narrowing. Mild to moderate crowding can be treated with expansion. Another situation where I can also use maxillary expansion is in cases where I observe that the patient has a respiratory problem. So sometimes the patient breathes poorly, snores, and I ask during the anamnesis, do you sleep well? The mother says, SOSO. I ask if the pillow is wet the next day, which means there is mouth breathing, and the mother says, yes, sometimes it is wet. These are signs the patient is not breathing well, and if this is accompanied by a narrowing of the upper arch, I can expand. You see, it's not only in cases of crossbite we perform expansion. The crossbite can be unilateral or bilateral. Basically, this is an alteration of the box-lid relationship. One moment, here I have a beautiful aromatic candle. So imagine that the maxilla is the lid and the mandible is the box. So when I have a narrowing of the maxilla, whether due to oral habits or respiratory problems, regardless of the etiology, I start to have a narrowing of the lid. And when I have a lid that's smaller than the box, I don't have a perfect fit of the upper arch occluding outside the lower arch. So that causes the upper arch to shift to one side when there's a certain level of narrowing, which would be a unilateral posterior crossbite. But if the upper arch is so narrow that it can't even compensate by shifting to one side where the maxilla truly doesn't fit anywhere, I end up having a slightly more severe situation, which would be a bilateral posterior crossbite. So our treatment will always aim to increase the lig, meaning the maxilla, so that I can always achieve a very perfect fit between the box and the lig. The question is, what protocol am I going to choose? Because that's the most complicated part. So here I have 6 types of expanders. I have a Haas appliance, which is this appliance that features an expansion screw combined with bilateral acrylic. I have a Hyrax appliance, which doesn't have this mucosal support and has the same structure as the Haas. And I have a butterfly appliance, which is a triangular screw where there is no posterior expansion, there is mainly anterior expansion, and it is used for intercanine expansion. These 3 appliances work in such a way that if activated at a certain rate, they will achieve a very rapid maxillary expansion. Now I have 3 lower appliances. Here I have a removable appliance. Here I have a leaf expander, a leaf type expander with a small nickel titanium spring. Here I have a quad helix. Its lateral arms are cut, but it's still a quad helix. They all perform slow expansion, but that doesn't mean that the upper appliance can't also achieve slow expansion. It all depends on the activation rate. If I decrease the activation rate and increase the amount of time, I can also apply this slow expansion protocol to a Haas, a Hyrax, or a butterfly. So, for example, if I do a quarter turn expansion twice a week, this is a slow expansion. So I have 0.5 millimeters opening week. Up to a quarter turn 3 times a week, I still consider that completely slow. So I can apply slow expansion with expanders. What happens is a RAS, Hyrax, or butterfly are devices that are more expensive. So generally, I don't use the slow expansion protocol for these 3 devices, and I don't want rapid expansion because a removable appliance is less expensive, a quad helix is less expensive. These differences exist. Rapid expansion is a high rate activations in a short period, and slower expansion is fewer activations a longer period. In this way, I have to choose which treatment I want for my patient. Slower expansion is more conservative, causes less pain and less discomfort. And rapid expansion, it is more invasive because it will break maxillary and circummaxillary sutures and it will separate these sutures. So when do I choose a more conservative, gentler approach, which is already sufficient? And when do I go for a rapid expansion approach, breaking sutures? So I have 5 steps to make this decision, 5 analyses that I have to do before making this decision, whether I go for rapid expansion or slow expansion, whether I choose the appliances for upper or lower arch. The first step is to evaluate the morphology of the dental arch. When I talk about the morphology of the dental arch, I am referring to an analysis that we do of the patient's occlusal aspect. What is the most important point to determine which expander appliance? So it is very important to evaluate the parabolic shape of the arch. I can do this using models. These can be digital, printed, or plaster models, or through occlusal photograph. Notice that here, I start with a very parabolic arch, then a more triangular arch, then a very triangular arch, and finally the most triangular. So the more parabolic, the greater the chance of performing an expansion. Dental expansion, and the more triangular, the greater the chance of skeletal expansion, which is rapid expansion. So evaluate arch morphology. Next, assess the vertical position of posterior teeth because the palate is small, narrow, constricted, but teeth are well positioned. This is one situation. And there is another situation where I have a more parabolic arch, but the teeth are palatinized. So this means that if I upright these teeth, if I move these teeth more towards the buccal side, I would already solve my problem. So in situations where the palate is wide and the posterior teeth are palatinized, I will likely go for a dental alveolar slow expansion. And if I have situation number 2, where the maxillary base is small and the posterior teeth are upright, I am dealing with a situation where I require skeletal expansion. The third step would be to evaluate the number of crossed teeth. So we will always use the criterion of seeing how many teeth are crossed in this posterior crossbite. How many are there? 2 teeth, 3 teeth, 4 teeth. Does all that make the posterior crossbite more severe? And the more crossed teeth there are, the more likely I am to choose a more skeletal protocol. The fewer crossed teeth, the more likely I am to use a dental or dental-alveolar expansion protocol. Everything I consider with what was mentioned earlier. It's not just about crossed teeth. It's arch morphology, as we saw in the second step, vertical position of posterior teeth and number of crossed teeth. Let's move on to our fourth step. Everyone looks at the teeth, models, occlusal photos, everyone sees. But someone is looking at the smile. Someone is looking at the buccal corridor. So before deciding to do an expansion and what type of expansion, we are going to evaluate the buccal corridor. So are there black triangles in the posterior area? Does this posterior area still need to be filled? Does it still need to be expanded? Notice that here I do see black triangles. In this second patient, I also see black triangles. And here it's even more severe because I see that there is already a posterior crossbite, and on this side of the posterior crossbite, more black triangles. So here in this third patient, we already see a complete buccal corridor. We no longer see a need to increase the bony base in the posterior area. So how do we interpret this information? If the buccal corridor is wide, if I see black triangles, I think about expanding the bony base with rapid expansion. Now, if the buccal corridor is complete and looks good, if I see that the teeth fill the smile in the buccal corridor, it means that I might be able to do a dental expansion, which is already more than enough, and I don't need to expand the bony bases. Up to this point, everything's good, everyone is calm, because we're moving on to our fifth and final aspect. So the fifth aspect that must be evaluated to decide between rapid and slow expansion is also something that no one sees. So the question is, are you looking at your patient's airways before recommending an expansion? Because if the answer is yes, congratulations, but let's see how you're doing that. But if the answer is no, we need to start looking at this aspect as an urgent matter. Airways can be evaluated in different ways with complementary exams, speech therapists, such as the water swallow test, or more precise analyses like tomographic analyses. But one analysis I really like, because it's already included in our documentation and initial exams we request from the patient, is through the lateral cephalometric radiograph. Is it the most reliable method? No, but it's easiest method for us to visualize. Notice we have airways in the upper part, airways at the nasal level, so that's the nasopharynx. So everything above the maxillary plane is the nasopharynx. Between the maxillary and mandibular planes, we have the buccal pharynx, or in other words, the oropharynx. And from the mandibular area downward, we have the laryngopharynx or hypopharynx. And we should keep in mind that the measurement of the airways, whether it's nasal or oral, the airway measurements in millimeters should be between 10 and 11 millimeters. This is supported by articles in the literature which mention 10.68 and 11.41. If I see a very small reduced space, it means there could be some airway obstruction. For example, hypertrophy of tonsils adenoid. In such cases, we should refer the patient to a doctor who can thoroughly examine these airways. But if I have a situation like this, a patient with significant airway restriction, look at this patient of mine It was unbelievable. I had never seen a patient so constricted because not even a sheet of paper could pass through here, maybe a strand of hair cord. The poor child could only breathe through his open mouth. So take a look here. There was absolutely no space at the level of the upper airway, but the lower arches were also deficient. And here I have a patient with a posterior crossbite, even a bilateral posterior crossbite, and maxillary growth restriction. In other words, the problem he has is with his airways, but that caused an occlusal issue. So you can address this respiratory problem together with the doctor. After we treated this patient, this malocclusion changed completely, and this child also stopped snoring, which is wonderful. So the fifth aspect to be evaluated is respiratory complaints. You can perform this radiographic analysis that I showed you. Evaluate speech, assess the resting position in photos, and perform analyses if this patient exhibits respiratory difficulties. And so, if you notice that there is this respiratory difficulty, we tend to decide on a rapid maxillary expansion. For patients without significant respiratory difficulties, we opt for a slow maxillary expansion. I know it's a lot of information, but this is valuable when deciding between rapid and slow expansion. In Module 5 of the Intercept course, already transformed thousands of dentists worldwide. Module 5 covers expansionist treatments. I explain step by step how to diagnose and treat, outlining protocols, differentiating appliances, noting differences, and precautions in appliance design, clinical cases, lower arch expansion protocols, and practical aspects are detailed in Module 5. Students attend, study, use resources, apply protocols easily. If you would like to receive information when we have the next group, because at this moment enrollment is closed, I have a link here. This is the link to the waiting list. I may open spots for the Intercept course a few times a year, either twice or once a year. If you're interested in being on the waiting list and receiving information before anyone else, as well as some special gifts just for those on this list. Sign up for the waiting list so you can stay informed when we have this opportunity. I hope you really enjoyed the video. You can also leave your opinion in the comments. Have a wonderful day and an excellent week.